Okay, it's a couple of minutes after the hour. I think, Dr. Macias, we can go and get started.
Ready. Welcome. Welcome and thank you for joining our session. I'm Charles Macias from Rainbow Babies and Children's in Cleveland, Ohio. I serve as the co-principal investigator along with Dr. Kate Remick for the Emergency Medical Services for Children Innovation and Improvement Center. You'll be hearing from four of our leaders at the EIIC today, each who will introduce themselves right prior to their section presentations. By way of acknowledgements, we have funding for the EMS for Children Innovation Improvement Center coming from the EMSC program under the umbrella of the Health Resources and Services Administration. Important to note the disclaimer that the content presented herein is that of the EIIC and does not necessarily represent the official views of or endorsement by HRSA, HHS, or the US government. For the next 48-ish minutes or so, you'll be hearing about the mission of the EIIC as well as the EMSC program, history of the EMSC program, a discussion of our brand and cascading missions, a little bit about our EIC structure, and more importantly, about the knowledge management domain and the work and resources that they do and make available to all of our stakeholders, including all of you today. The EMSC continuum of care illustrated in this slide in the red and blue circle does not only focus on the pre-hospital and hospital-based emergency care, but spans incident recognition to pre-hospital to hospital-based care and a return to the community, also enhancing injury prevention and community-based care models. The mission of the EMS for Children Innovation Improvement Center aligns with that of the EMSC program and its parent governmental entities, which you will hear more about. The mission of the EIIC is to collaboratively leverage quality and safety strategies to minimize morbidity and mortality of acutely ill and injured children across the emergency care continuum. Our vision at the EIIC is that one day every child and family will receive the highest quality emergency medical care through EMSC optimized systems. So understanding the EIIC and the resources it provides necessitates a quick look back to the Emergency Medical Services for Children federal program and how it began. With lessons learned from the Vietnam and Korean Wars, legislation in the 60s and 70s supported the infrastructure of the national EMS systems that were developed. However, it soon became clear that as outcomes were improving for adult trauma and cardiac disease in particular, that outcomes in children were not equally improved. And that scrutiny led to a desire to see legislation drive systems improvements that would reduce childhood death and disability from severe illness or injury and enhance the pediatric capability of existing EMSC systems. So thanks to the efforts of Calvin Sia, president of the Hawaii Medical Association at the time, along with Senator Dan Inouye, such legislation was introduced. And in 1984, the first iteration of the Emergency Medical Services for Children program was born. It was created and funded under the Maternal Child Health Bureau within the umbrella of the Health Resources and Services Administration under the direct supervision of the Department of Health and Human Services. The intent of the EMSC program was not to promote the development of a separate EMS system for children, but rather to enhance the pediatric capabilities of existing EMS systems. So as the only federal entity charged exclusively with providing oversight and support for emergency care initiatives for children rather than for adults and children, the EMSC program is supported by many assets. Today, the EMS for Children program achieves its mission by providing funding support and coordination for several programs and centers that each target specific strategies. The first of those is the infrastructure support through the state partnerships. That exists in 58 states and territories and serves as the foundation or infrastructure for the work of the EMSC program to enhance pre-hospital and hospital-based emergency care for children. Next is the National EMSC Data Analysis Resource Center, or NEDARC, based in Salt Lake City, which provides data collection and analysis support for national initiatives of the EMSC program, including performance measures that provide accountability for the EMSC grantees. The state partnership regionalization of care grants work to develop and implement regionalized systems of care that encompass or include the sharing of resources, improving access to pediatric healthcare services in tribal, territorial, insular, and rural areas. In short, it provides for system integration. Targeted issues grants, listed second to the right, drive innovation through the provision of support for investigator-initiated research to address gaps in knowledge in emergency care for children. The Pediatric Emergency Care Applied Research Network conducts high-priority, multi-institutional research on the prevention and management of acute illnesses and injuries in children. They are generating the science and evidence within the EMSC space, bringing us such transformational studies such as those describing the PCAR and TBI rules. You heard a lot about this in the opening plenary delivered by Dr. Nate Cooperman. Finally, the EMSC Innovation and Improvement Center, the newest of the family of EMSC programs, began in July of 2016 to drive healthcare transformation through the quality improvement and safety science opportunities. So that being said, before I described all these entities, did you know about the EMSC program? To be transparent, we suffer from brand identity. But in contrast, what do these images you see on the screen conjure up? Nike and Apple, each company, a brand, a way of life. A brand representing the sum of people's perception of an entity's reputation, their service, their advertising, and their logo. It allows messages and efforts to cascade from a single strategy or a single mission. A brand should instill trust for all its stakeholders with everything it represents. So in this next slide, you see the brand, the EMSC bear, relating hopefully to the mission of the EMSC program in a cascading fashion to all of its entities or assets. Unifying that brand should make us all recognizable as a part of the Emergency Medical Services for Children program. PCARN, the state partnerships, the EIIC, and NEDARC, all a family of companies, so that we can leverage the best practices across the companies and synergistically amplify our efforts to drive innovation, generate knowledge, disseminate it widely, while improving the national infrastructure to transform care through quality improvement, all to drive better outcomes for ill and injured children by making healthcare more pediatric ready. Kate?
Great, thank you, Charles. That was a wonderful introduction. My name is Kate Remick. I am a physician at the University of Texas and executive lead for the EIIC, or EMS for Children Innovation and Improvement Center. So with that orientation, while we're working towards a singular brand, this is currently our state today. And within the EMS for Children program, there are several investments that we just want to highlight. One of those is the state partnership programs, which exist in all 58 states and territories to support the integration of pediatric readiness within the overarching emergency care systems. Additionally, we have the Pediatric Emergency Care Applied Research Network, 18 nodes where evidence base is derived to support the needs of children in the emergency care setting and extending into the pre-hospital setting and EMS systems. Additionally, we have the National EMSC Data Analysis and Resource Center. This is the accountability arm that Dr. Macias just alluded to, where we're really able to collect data and analytics relative to the program as a whole and report back to Congress to help support ongoing funding for the federal program. State partnership regionalization of care grants reach out into remote and rural regions of this country to support integration of pediatric readiness needs into Indian health services and tribal areas, as well as those more just remote areas across the nation. And then finally, our targeted issues grants, which are really innovation grants designed to improve systems of care at the local, regional, and eventually national level. There are currently 5 targeted issues grants within this program, one within North Carolina, one in Connecticut, one based out of Louisiana, one in Texas, and one within Oregon, all of which are focused on pediatric readiness. And then last and finally is the EMS for Children Innovation and Improvement Center. And I wanted to spend a little bit more time talking about this particular investment within the EMSC family. We'll go to the next slide. So this is an overview of the leadership within the EMS for Children Innovation and Improvement Center. You'll see myself and Dr. Macias, as well as Dr. Corey Chimpatazi, also speaking on this call today, Dr. Mosa Jinajad, who's based out of Harbor, UCLA at the Lundquist Institute, and Dr. Mark Auerbach at Yale University in Connecticut. Within the EMS for Children Innovation Improvement Center, we know our successes would not be as significant without the support of our national partnering organizations. And we have formalized relationships with the American College of Emergency Physicians, the American Academy of Pediatrics, the Emergency Nurses Association, the American College of Surgeons Committee on Trauma, and also the National Association of EMS officials. And it's critical that we have these formalized relationships in order to support ongoing activities across this country. If you look at this overall org chart, you'll see that, generally speaking, our focus is on improving pediatric readiness across the entire continuum. We have created kind of divisions of areas of focus within that. And what you'll see in these vertical bars or blue bars are our core areas of focus to make sure that we achieve goals relative to disaster preparedness, trauma, pre-hospital emergency care, hospital-based care, our state partnership programs and infrastructure, and then of course the integration of research throughout. Additionally, we have cross-cutting domains related to knowledge management, which you'll hear more about, related to advocacy work through our family advisory networks, through quality improvement methodology and quality improvement collaboratives, analytics, and of course, value-based care. And all of this is possible through the support of those partnerships I mentioned, and also the Centers for Collaborative and Interactive Technologies based at Baylor College of Medicine that supports our overarching webpage. Move on to the next slide. So in order to improve the outcomes for children in urgent and emergent care settings, we've really taken a three-part approach. The first is that knowledge management is key to this. We want to make sure that we're able to push out content and disseminate it widely, and that that content is founded on evidence-based practice. Additionally, if you move to the next, we focus critically on quality improvement methodology as a foundational component to all the work that we do. We know that through quality improvement, we can much more rapidly transform our emergency care systems on the order of a 3 to 5 year period rather than a 10 to 18 year period that we see with passive uptake. And then most importantly, in addition to this, is that we have robust analytics to be able to help demonstrate our improvement over time, also to be able to demonstrate back to our federal partners that we are indeed seeing adoption and integration of pediatric readiness across our emergency care systems. With respect to our quality improvement collaboratives, these are really founded on the Institute for Healthcare Improvement model, breakthrough series model, but with some additional caveats to that. Our goal is to launch quality improvement collaboratives that are of a national scale. We want to make sure that they are robust in being able to achieve the needs and diversity of our partners across the country. That includes partners in rural areas, partners in urban areas, and making sure we're really meeting the needs of patients and families that are at the heart of what we do. All of our quality improvement collaboratives are based on evidence-informed content. We use quality improvement methodology. We have robust project management and IT infrastructure, as well as data management support. And then of course, the analytics and research that drive this. These collaboratives are mostly successful because of the support of our partners. That includes families. It also includes those national professional societies and organizations that I mentioned, not just those 5 that are formalized within the EMS for Children program, but also our partners that exist across the country. And we drive these collaboratives through iterative cycles. So one of our most robust collaboratives is really the National Pediatric Readiness Project. And this was launched in 2012 with the support of those national professional organizations that we just mentioned. And the goal of the National Pediatric Readiness Project is truly a national quality improvement collaborative. Similar to all of our other collaboratives, we're measuring our baseline readiness, identifying opportunities for improvement, making a series of interventions or change strategies to drive those improvements, and then remeasuring or reassessing our improvement over time. What you see demonstrated here is a link to really an infographic that describes some of these steps along the way. So while the initial National Pediatric Readiness Project launched with an assessment in 2013, since that time, we've tried to implement a series of change strategies or improvement efforts that are quality improvement collaboratives that include the development of readiness toolkits, the development of checklists and resources, education modules, the launching of a series of quality improvement collaboratives that I'll walk through in just a few moments, And then we have future collaboratives on the horizon that includes the PEC Workforce Development Collaborative that'll be launching in September, and then a national pediatric readiness quality collaborative that'll be launching in the next couple of years. So we'll talk more about that. As many of you are probably aware, we are now in our second phase of reassessment. So the National Pediatric Readiness Project reassessment just launched on May 1st of this year. We're excited to be able to demonstrate improvements over the last 7 years since we initially launched this effort, and really see where there may be still additional opportunities to engage folks in making ongoing improvements. So we hope everyone will participate. Again, this launched on May 1st. It'll extend through July 31st. If you go to the website pedsready.org, you can find the assessment there. Please work with your ED nurse managers and ED leadership to participate. Only one assessment should be completed per site. So please make sure you work with your leadership. In terms of our quality improvement collaboratives that we've launched over the last few years, the first one that we wanted to highlight is the Pediatric Medical Recognition Program. This was launched in 2017, and the goal of this program was to create pediatric medical recognition programs akin to STEMI, stroke, and trauma centers. So how can we make sure that all emergency departments are robust in being able to have the basic infrastructure to meet the needs of critically ill and injured children? We started this with really only 5 states that had pediatric medical recognition programs in place. That has grown over the last decade to 8. And then with the support of this collaborative, we now have 17 states that now have pediatric readiness recognition programs. You see those programs highlighted in blue. If you live in one of those states, you work in an emergency department there, we would encourage you to reach out to your EMSC state partnership managers to see how your emergency department can be recognized as a PEDS ready facility. It's important to realize that the goal of this is not to focus on children's hospitals and large comprehensive medical centers, but really to engage those centers where we know communities rely heavily on them, in rural and remote communities, community EDs where we know so many families will turn to for emergency care needs. The next collaborative that we launched was the Pediatric Readiness Quality Collaborative. This was more of a grassroots effort of working with physicians and nurses on the front lines to implement quality improvement processes and plans. We learned from the 2013 assessment that one of the biggest gaps was having a quality improvement plan that includes the needs of children. One of the challenges is understanding QI methodology. The other challenge is knowing what metrics to use to really drive improvement efforts. We launched this collaborative with 130 emergency departments across 17 states. And the focus was on core system processes. So making sure children were weighed in kilos, making sure that vital signs were fully assessed and reassessed in order to recognize the critically ill child, to recognize those children that are in need of higher level resources to be transferred and optimizing those transfers. And lastly, implementing disaster planning processes for which we knew less than 50% of emergency departments had included children. So this was a really exciting initial quality improvement collaborative to really drive some of those efforts. And we're looking forward to PEDS Ready Quality Collaborative 2.0 that'll be launching in 2022, where we hope we can engage as many, if not more sites as this initial collaborative. Currently underway, we have a telehealth collaborative. This is focused on working with 8 teams, the states of Kansas, Oregon, Pennsylvania, Rhode Island, Utah, Vermont, Wisconsin, and then a Hawaii American Samoa team. And the goal of this particular collaborative is to really see how we can increase access to emergency care services utilizing telehealth. And the focus was specifically knowing the impact of COVID and the pandemic on children with behavioral health emergencies, which we know have become of epidemic proportions in this country over the last decade, worsened by COVID, and then also children with special healthcare needs who may face particular challenges in achieving access to their usual healthcare providers due to closing of clinics or risk factors in terms of exposure to COVID. So we focused on 9 key drivers, and we're really excited to see the progress that's being made by these 8 teams. Lastly, I wanted to speak to our disaster planning collaborative. This was really a collaborative effort with the ASPR Pediatric Disaster Centers of Excellence, the Eagle Network, which Dr. Macias helps to co-lead, and the RAPIN group, the Western Region group, co-led by Dr. Chris Newton and others. And within this disaster collaborative, the goal was really to help train and reinforce the key components of disaster planning. These teams worked through a series of 9 areas of focus, or 9 modules, focused both in the clinic setting and the hospital-based setting. You can see the degree of engagement that extended not just within the United States and across the country, but even into Canada, and really exciting to see the results that were developed here. Over the coming months and weeks, you'll see the development of a disaster toolkit to support these ongoing efforts. And that's true of all of our quality improvement collaboratives, is to create toolkits that will support ongoing activities and efforts even after the formal quality improvement collaborative closes. And then what is upcoming here shortly in September is our PEC Workforce Development Collaborative. And we know that one of the key drivers of pediatric readiness is having a champion on site to really ensure that the needs of children are being fully integrated into emergency care systems. And this was called out in the Institute of Medicine report in 2006. We've made some significant strides over the last decade to really help support pediatric champions to become even more formally pediatric emergency care coordinators. And the focus of this 9-month collaborative that'll launch in September is to really help individuals on the front lines, both EMS practitioners, nurses, physicians, and our EMS for Children state partnership managers to really become more effective in this role of being a champion. And that includes being able to effectively communicate, being able to really develop robust policies, protocols, and procedures, to implement care team competency programs, to develop quality improvement plans and the like. And we're really excited to be launching this. This is, of course, free open access, and our goal is really to help drive that workforce development. And we hope all of you who are interested in being that pediatric champion will join this collaborative with the expectation that it would be about a 2 to 3 hour commitment per month. And then our next slide. So the last thing that I wanted to just speak to is our EMSC state partnership programs. Within all 58 states and territories, we have an EMSC state partnership program. These are funded through our federal partners, and these individuals are working hard to integrate the needs of children into their state emergency care systems. If you don't know who your EMSC state partnership program manager is, you can find that easily on the EMSC Innovation and Improvement website under our funded grant program, where you'll see state partnership managers. You can see here on the right-hand side is a map of all of our EMSC state partnership programs. Those highlighted in orange are those that are housed within the State Department of EMS or their Health Services Division. Those highlighted in blue are housed in academic centers. We work closely with all of those. What's important to recognize is within each of these states and territories is that our EMSC state partnership programs have advisory councils where we've engaged emergency medicine physicians, nurses, EMS practitioners to really help drive some key activities and efforts within the EMSC program. And if you'll go to the next slide, what you'll see listed here is that within each of these EMSC state partnership programs, the goal is to really look at these federal EMS for Children performance measures and really help to make improvements towards these goals. The first 3 are focused on pre-hospital areas. So making sure that we're gathering data that's NMSIS compliant, the National EMS Information System. In addition, making sure that there are pediatric emergency care coordinators within EMS agencies, and that we're implementing processes to ensure that all EMS practitioners at the agency level are trained in how to perform critical skills in the pediatric population. You'll see that the next 4 areas of focus are really within the emergency department setting, developing recognition programs for pediatric emergencies and trauma, also developing and improving and optimizing our interfacility transfer guidelines and agreements. And then the last 2 areas are focused on formalizing the EMS system to include the voice of pediatrics. So making sure that the EMS for Children program is embedded within the EMS system, and it's integrated within statutes and or regulations. So as we continue to drive pediatric readiness forward, this just provides a high-level overview of the quality improvement collaboratives that we have in place. And at the close of all of these activities, we do develop communities of practice that are ongoing efforts to build those networks and drive improvements. And at this point, I'm going to turn it over to Dr. Mosa Dinajad to speak to knowledge management.
Yeah, good morning, everyone. I'm Mosa Dinajad. I am one of the members of the executive lead for EIIC. I'm also one of the co-leads for the knowledge management domain, along with my colleagues, Dr. Corey Chumpatazi and Dr. Mark Auerbach. I'll talk to you a little bit about the structure of the knowledge management domain, which is one of our cross-cutting domains in that slide that you saw earlier about the structure of EIIC. So the knowledge management domain is based on 3 interconnecting pillars. Every content that we develop or identify is first going through evidence synthesis, evidence-based practice. That is led at the center at Texas Children's Hospital, Baylor College of Medicine, and Dr. Corey Chumpatazi leads that. And then when we're talking about developing content, curating content, or identifying content to be displayed, that is going to be my domain at Harbor UCLA, the Lundquist Institute. And then our dissemination and implementation part of this is at Yale New Haven Children's Hospital, and that's led by Dr. Mark Auerbach. All of these 3 pieces are interconnecting, and the 3 of us work very closely together on any of the content for knowledge management domain. We're using a process called knowledge to action cycle. And what we do, for example, we find a specific disease-based, topic-based, and we look at areas where there is currently a variability in practice. We try to identify a best practice and try to develop a toolkit around that best practice. And then we will get feedback from the intended end users on the usability of that toolkit. We look at all the barriers for implementation of such toolkit. Then we basically would put it through our website and put analytics around it so we can kind of measure the use of the toolkit. We obtain general feedback after the toolkit has been on our website. Then we're going to make iterative improvements based on suggestion. And finally, plans for sustainability and implementation is part of how the cycle works. Again, in terms of research development, first we do a needs assessment and a gap analysis. We brainstorm about what kind of deliverables can we develop around that topic. We develop our prototype, we test it, and then we seek feedback and make iterative improvement. Again, this is a repeat of the same slide that I'll tell you about. The center for all of our knowledge management content is our EIIC web portal. We wanted to have a one go-to repository for all of the content that we create. We want it to be intuitive, simple, easy to find what you're looking for. We want it to be able to interface by a variety of different devices. We want it to be adaptive to the screen. So no matter what device you use, you'll see the content in the same format. It doesn't cut off on the sides. It will display properly no matter what device you use. Also responsive in terms of its ability to take feedback, make improvements, and so that the end user has a stakeholdership in the content that we develop. We want it to also be dynamic. So every time you go to the web portal, there is something new. We make an effort to constantly update content. We also verify that the content that we have is appropriate and still up to date. And this all will be at our website that I have in the bottom here, emscimprovement.center. So please go and visit our site and take a look. We have a broad range of end users or target audiences that we are developing this content for. Those are the 4 what we call personas that range from the lay public, patients and families. It also includes the EMSC stakeholders such as target issues grantees, PCARN, and our other EMS members of the family. The scientific community, which ranges all the way from pre-hospital to hospital-based, including physicians and nurses and researchers, as well as child health advocates such as the Family Advisory Network. We have specific topic areas. Every year we choose 2, and I'll talk to you about that a little bit more. This year, for example, our two topic areas are going to be status epilepticus, which is it actually completed by now. And then the second topic area will be mental health, which is currently in development and is planned launch in early summer. We wanted to make sure everything we develop has a rural health lens to it. We want to make sure that this is useful for areas of low resource, the ones who probably need this information the most. We also want to make sure that there is a lens of diversity, equity, and inclusion on that. We have collaborators that we work with, and we have various strategies for disseminating our content. So in terms of how we do this, first, we either identify content that is already vetted and is appropriate for use. So we prefer to have more of a collating function in terms of getting all the information put together in one place. There are sometimes content that just need a little bit of updating, but they are pretty much good as they are. So those will be content that we curate. And whenever there's content missing and there is something that we need to develop, then we'll of course develop. We wanted to keep within our goals of the topic areas and ability for the end user to have a smaller segment, as we call it, bite-sized pieces of information rather than very prolonged long videos or big articles or anything of that nature. We want it to be very simple and somebody can look at it at the time that they need it, take 5 minutes, maybe 10 minutes, and be able to get their information. We're going to offer a variety of modalities. We're going to have anywhere from webinars and podcasts to simulations, virtual reality gamings, as well as infographics or interactive learning modules. We have in this partnered with a few of the organizations, for example, Trek, which is an international company based in Canada. They have done some amazing work in developing a series of clinical pathways and practice algorithms, as well as bottom line recommendations. So we just partnered with them most recently to work on a status epilepticus algorithm. We also partnered up with Open Pediatrics, which has a very, very robust infrastructure for a learning management system. And they're helping host our learning management, hosting our interactive learning modules. MRAP is also partnered with us. We're doing podcasts with them, and those are also going to be part of our offerings. So this is the slide I wanted to talk to you most about. This is how you can get involved. There's many ways that you can get involved with the EIIC. One would be to help us with contributing content. You can always send any content that you have to our email, km@emscimprovement.center. We review everything that we get, and we will put them up for our expert review. And if it ends up meeting the standards that is required for it to be published, then it can get published. You can also request to collaborate with us, both in developing content or sharing content or anything related to that. You can also get involved by helping us review, as an expert reviewer, the content that we have that are sitting in our early access area. I'm going to talk about that in a second. So every content that we're considering for publication first gets placed in a non-public area of the website, and we will then request feedback for that content, and based on the feedback and ability for us to either publish or publish after some minor changes, we will decide to publish those, and anything that's deemed to be not suitable will basically not get published. And the final way is that you can help us get the word out, share with your local and your regional community, your organizations that you're a part of. So those are the three ways that you can get involved with us. Just quickly showing you how you can get involved with the review process. Again, you go to that same website, the EMSCimprovement.center. Under the education tab, you find a topic heading called Knowledge Management Early Access Program. This is, again, the non-public area of the site. And you basically, when you click on, you say register. When you register, if you have an account already, obviously sign in, but if not, you say create account. And when you click on the create account, this information will pop up. Then you will put in your information, including selecting a password. You actually put your roles in. You can have more than one role, so you click as many as apply. And the most important part is that you will click on this box that says, I would like to receive early access material from EIIC, and then say create account. By clicking on the early access, you will have access to this area and you can be a reviewer for us. So an example would be when you go look at the early access page. This is our April early access program content for suicide screening. You see how long the time commitment is for reviewing it, or how long it takes for somebody to actually view it. So you see these are all smaller, just-in-time content. You click on a topic, and then when you view it, you click on submit feedback here, and that's how we get your feedback content.
Great.
With that, I'm going to pass on to Dr. Corey Chumpatazi, who will be talking about the contents actually published and then beyond that. Thank you, Corey.
Wonderful. Thank you, Dr. Sadanajad, with that introduction. And you've covered a lot of the content that we're just going to dive into in a little bit more detail. And to just add to what he was stating about our access is available to all people who click on the website without registration. However, if you do sign up to receive content and get access to give us feedback, we'd really greatly appreciate that, because we really wanted to design resources that are helpful to you. And so we encourage you to do that. This is the page for our pediatric emergency and advocacy kits. So as we discussed, if you go under education and click down to those kits, we're developing a wide variety of toolkits, and you can keep that one, Mo, starting with status epilepticus. So that first slide on that left shows our status epilepticus, and then shows where our newly developed content for suicide screening, as well as mental health safety and agitation and approach to an agitated patient, is under development with some of our partners that have been mentioned. And then if you just use your phone to use the QR reader on the slides, you could do that as well. So here then on that next slide is drilling down into what how we've laid out the page to try to be easy to navigate for you. So looking at that left side, you have clinician access for clinicians, for nurses, for patients and families, for pre-hospital professionals. You're not obligated to not click in the other sections if you're not those providers, but they're to help you navigate easily through that content. As well, in those boxes to the right, we see that the practice guidelines, videos, there's podcasts, there's different patient and family videos and webinars. And so there's an opportunity to look through that content. And we do try to know that you are busy, and you want to know how much time it's going to take. So here again, you'll see the approximate time it'll take to watch those videos. As far as how we develop our process for making these toolkits, we start with a lengthy topic. So for example, mental health was an extremely exciting topic for us, extremely timely, and we were able to build on the critical crossroads toolkit that had been developed by the Health Resources and Service Administration's Maternal and Child Health Bureau that partnered with several of other offices, primarily the Federal Office of Rural Health Policy, but many others and many of our content experts throughout the EMSC assets and PCARN and others to develop this toolkit. So we were able to start brainstorming, getting those content experts together in early January and throughout last fall, already strategizing the process, working with the editorial group throughout the spring, and then working with our partners to develop these tools and resources. And now we're getting ready for some product testing and vetting of those podcasts that you're able to access through our Keep content, with goal of launching this toolkit in early July. So that's just a sample of how we all work together throughout all of the EIIC programs and in partnership with the EMSC to accomplish this. As far as the research and evidence, as Dr. Sadanajad mentioned, I've also co-chair the research domain with Dr. Rachel Stanley out of Nationwide Children's Hospital. And so we really are working with the evidence with all the different programs that Dr. Macias and Remick had mentioned. So working with our TI grantees to really just think about how we can transform and really close that gap into practice so that we can improve the care of children sooner than, as she mentioned, that 13 to 15, 17-year gap. So that's been really exciting. And then assisting PCARN with some of their responsibilities, the webinars and those kind of things, as well as then just getting the quality evidence. All of our resources and tools start with the evidence and quality content first. So we are really excited to have been able to launch the EMSC Scholars and Fellows program this year to really grow the next generation of EMSC leaders. So we're targeting early clinicians and health systems trainees with an appointment of a 1-year commitment, but possibility for 2 years in a program that we have labeled the Scholars and Fellows. And you'll see the differences in those programs in the boxes below. But mainly thinking that our scholars are a more intensive program with asking to commit several hours per week and getting commitments from their leadership to allow them to participate in this program. And then the fellows with a little bit less time commitment. Some are medical students or other folks that have variability responsibilities, but a really awesome opportunity to get them involved in all the areas that we've been talking about today. Next slide, Mo. For our initial inaugural scholars program, we were able to take 6, and then we had 30 fellows. We far exceeded our expectations for applicants and just had such a phenomenal pool and have assigned them to our various domains throughout the EIIC. And many of their projects and interests span some of these areas, and they're really getting involved in many different areas. We had over 94 completed applications, resulting in the stats there. And if you look at that graph, we had a wide variety of applicants from across the country and Canada, as well as several territories and other countries represented. So we have kicked off this initial class that will run through next April of 22, or next probably June next summer, and then we'll aim to reopen those applications. So this is another really amazing opportunity, and we'll put those the link to those pages. If you go to the next slide, you'll get to see our just phenomenal scholars. There's more information about these fantastic folks on our website, and so you can read a little bit more about them. But I think it's really exciting to note that we have a variety of folks on this scholars program. So not just physicians, but we've had nurses, advanced practitioners, pre-hospital personnel, professionals, as well as child life specialists and trainees. So just a really great opportunity, and just really excited to see where these folks take their projects. As we mentioned, the equity and diversity, we would be remiss if we thought that these disparities didn't impact children as well as all in healthcare. And so we've really taken a concerted effort with our equity, diversity, and inclusion, our EDI work that stems out of our advocacy domain, chaired by Dr. Sarah Ronis. And so there is the what and how, and we partner with the Disparities Committee within PCARN and several other assets throughout the EMSC and HRSA to really try to think about how we can work on this in regards to children. And then here are our core goals in regards to both equity, diversity, and inclusion. And these statements are posted on our website as well, but a real focus in all we do to make sure that we're thinking about this and how it impacts the care we deliver, how we educate, and the programs we design to try to help mitigate and eliminate these disparities. So these are our contact information. We can provide these in the chat as well, but I really want to use the last of our time here today to answer your questions. I see a robust chat, so I'll turn it back to Dr. Sayanajad to moderate our question and answer session.
Okay, let me see. I have to take this back. So one thing that I saw earlier on that Julia had mentioned, how do we see to it that our state is one of this is a question for Dr. Remick. How do we see to it that that our state is one of those 17 states that's getting involved in the collaboratives?
Yeah, thanks for that question. If you can see within the chat box, I posted a link to the EMSC Innovation Improvement Center's website where you can find our grantee contact database. That lists all of the EMSC state partnership program managers. You can search specifically for your state, and what you'll find is a contact information for that individual. I would encourage you to go ahead and reach out to them directly. You can email them, let them know of your interest. If you're one of those 17 states that currently has an EMSC pediatric medical recognition program in place, they can provide you with additional information on the application process, the requirements, and the like. But thanks so much for your interest. I think the more and more emergency departments that become pediatric ready facilities, the better we're able to really impact these changes on a national scale. Thanks.
And then a follow-up to that is, as someone who works in a children's hospital, what is the best way to engage my surrounding community hospital EDs and help them be more prepared for pediatric patients?
Sure. So I'm happy to take a first response for that as well. So we have developed a number of processes and quality improvement collaboratives that really target that level of networking. We know that this is pretty robust within trauma systems and that there's really a requirement and an effort for community outreach within trauma hospitals, but we're trying to make sure that that exists as well on the medical side. Within the Pediatric Readiness Quality Collaborative, we did help to establish some of those networks. One of the other pieces that I would mention again is reaching out to your EMSC state partnership managers, because they have multiple connections across the state and region and can help to provide some support in terms of resources, potential activities, ways to get involved in the quality improvement collaboratives that are housed at the EMSC Innovation and Improvement Center, and really help to support that relationship building. So if you have any questions about that, I'll put my email in the chat box as well. And you're welcome to reach out to me directly or work through the EMSC State Partnership Manager. And I don't know if Dr. Macias or others have comments on that as well.
Thanks, Kate. Completely agree with everything that you described. I think that there are, outside of the collaboratives, opportunities to also engage one-to-one with any of our current staff, but specifically if you want sort of a consultation for what currently exists within your state and want better communication with that EMSC advisory committee within the state and interlink all of these opportunities. We'd be happy to help you navigate all of that. And that may have been what you were alluding to, Kate. So apologies if I distorted your description. But I think really it's very helpful in a world that's so incredibly complex in healthcare to have an ambassador from our group help really help champion you through this work.
Thank you so much. I think the other questions, you guys have already answered them during chat, so I think we're good. Unless there's any additional questions.
No, so just to reiterate, follow us we're also on Twitter and Facebook. And so just get involved and use the resources that have been provided to reach out and impact the care of children. And we're looking forward to partner with you in the future.
Yeah, and just to follow up on that, every content that we have on our web portal is available without the need to be registered or needing to go through any password system or anything like that. But if you do register and you're a registered member of the site, that gives you the opportunity to get communication from us and also helps us do a better job at analytics of who's actually the people that are viewing our content. So while it's not required, we, as Corey mentioned this before, we encourage you to try to log in, register, and go through our logged in session so that we can capture that, track the activities and be able to see what areas have better traffic that need more use of additional content development and things of that nature.